Okay. So for those of you who saw my original talk title, don't be disappointed. We will be covering those topics. But as I got to putting together the slides and really thinking about what I wanted to say to you today, I thought this was a more fitting title. What about justice? So before I delve into kind of some of the content that I want to talk about today, I'd like to give you a little bit of background of how I got interested in this topic and how I came to be someone who studies justice and health and equity. Maybe I want to do that. I can get my slides to move forward. Let's try that. Mhm. All right. Now my slides are moving forward now. So I have a screenshot here of a very young picture of me from 2010. That top picture is me in my happy, bright, and unjaded face as a fresh graduate getting my match letter to man's greatest hospital. And that picture below is a picture of my headshot. Again, bright, naive, happy, excited, ready to go into the world. And so, as a medical student at Case Western Cleveland Clinic Learner College of Medicine, my third year, I was pretty sure that I wanted to do GI and hepatology. And so I was doing a rotation, and one of the residents said, you know, one of your patients is going to be presented today in liver transplant committee meeting. Why don't you go to the committee meeting? And I said, okay. I said, I think he's just trying to get rid of me, but it may be interesting. Okay. So I went, I sat in the back, and I came in with this kind of idea of what I expected to happen. I expected like a big screen to come down and for like all the names to go up on the board and for everybody's clinical information to come up and there to be this rigorous discussion about how we can get people to transplant. And that wasn't what it was. My expectations did not get met. And I can say since that time, I have been to many transplant committee meetings at different centers, and there was nothing wrong with the transplant committee meeting that happened at Case Western. But it was not what I expected. It was people eating lunch, people answering pages, people saying why people weren't eligible without thinking about solutions. It was what to me seemed like very casual for something so substantial. And my patient was not listed. It was thought that he did not have enough social support, and it was given very short discussion. And I was shocked. I left that committee meeting, and I remember telling my senior, I can't believe this is how committee meetings go. Was this some type of anomaly? Nobody seemed to be trying to help this patient. And he just looked at me and shook his head. And then I had the same conversation with family and friends afterwards, and nobody was quite sure why I was so bothered, but I was very bothered by the whole thing. And so I said, well, I want to be able to talk about this and use some terms and talk about these things that I'm feeling and experiencing and this fairness that I feel like is not there in some kind of educated way. And so I started Googling liver transplant and fairness, and I came across some things by Art Kaplan and other folks, and I said, maybe if I take a bioethics class, I'll be able to kind of express what I'm feeling and talk about it in a more meaningful way. So I took a bioethics class, and a bioethics class turned into a bioethics master's. And that's how I landed in this space, really wanting to be able to express what I was seeing, the problems I was seeing in some type of way that wasn't just emotional, that wasn't just, this doesn't seem like it's right. And that's how I became kind of, or got on this path of exploring justice and social justice from a bioethics framework. So I learned a lot of different ethical constructs in transplantation as a bioethics student. That did arm me with some tools to write a lot of good editorials, and so we'll run through some ethical constructs in transplant. I learned about scarce resource allocation. right? And this idea that there's not enough to go around, and you've got to think about how to distribute them fairly and effectively. And I actually wrote my kind of master's thesis around this concept of scarce resource allocation in kidney transplantation. I learned about distributive justice, this concept that even in the setting of scarce resource allocation, you have to still understand how the burdens and the benefits in healthcare are allocated and distributed amongst all individuals. And so that seemed to get at a bit of what I was feeling in that committee meeting, that yes, there's a scarce resource, but how can we ensure that some people aren't bearing all of the burdens? Autonomy, of course, was something that I learned about, that, people have to make informed decisions about whether or not they want to partake in healthcare, even transplant. It's a life-saving endeavor, but everybody doesn't want to do that, and that's okay. And there's going to be some people who need to be able to express that kind of autonomy, that they aren't interested in transplant for whatever their reasons may be. We learned about how to be a benefit, right, to patients, and really thinking about transplant and the people who are going to have the best survival. And so that becomes a big topic and a big focus that we'll talk about more in transplant. And of course, we want to do no harm. We want to pick the people who are going to have the best outcomes. And then finally, some of the concepts that I thought about were moral distress. And so I think sitting in that meeting, I felt a bit distressed, some discomfort as a clinician, and feeling like there was some injustice and that there was nothing that I could do about it. And so I was armed with this framework, and I've written editorials, and I've thought about these concepts and how they apply to the patient that I saw in medical school and many of the patients that I see today. But I still have to say that even over a decade later, I'm left with this question. It doesn't burn me in the same way it did as a medical student, but I still feel like of the four major ethical principles in transplant and in healthcare: autonomy, beneficence, non-malfeasance, and justice. Why does justice receive the least attention? Why is justice the stepchild of all of the ethical principles? And what can we do about that? And what would it look like? What would healthcare look like? What would transplant look like? What would the world look like if justice were treated as an equal ethical principle in transplantation? And so, armed with kind of the framework about how to think about these things, this is the question that drives me every day. This is why I get up every morning. This is why I do the work that I do. This is why I apply for grants in the face of executive orders, because I want to know, what would the world look like if people cared as much about justice as they did about autonomy? So, these are objectives that we will cover today. We will examine those four ethical principles, and we will talk about how they're coded into healthcare and transplant. And we'll talk about how justice really is not. We will then review some of the disparities in liver transplantation and highlight some key access and outcome issues that I think happen as a result of really our lack of focus on justice. And then we'll talk about the consequences of a failure to deal with our justice issue. And because I think that there's this idea that not dealing with justice and not dealing with health inequity is somebody else's problem. But injustice has consequences. Okay. And so we're going to talk about public perception, injustice, and the consequences in organ donation of our lack of focus about justice and trust. And then we're going to dream and talk about, what if we were to reimagine a just transplant system? If I could have some of the things that I would like, that I would think would move us away from where we are now, what would they look like? And so we'll end on a high note. So let's start with talking about some of the ethical principles in healthcare and transplant, and how they are coded in a part of our kind of framework in a way that I think justice is not. So, autonomy is a patient's right to make their own medical decisions. We all understand it, and it is legally protected. Okay. The principle is reinforced through informed consent, shared decision making. Um, if I leave an endoscopy room and I have forgotten, I've talked to the patient about the procedure, I've explained it, but for some reason I didn't get their signature and I didn't sign the consent form, there's 5 nurses chasing me down the hallway to make sure that those consent forms get signed before I put that scope in the patient. Okay. And so we have processes in place to make sure that patients' autonomy is documented. There are many of us in ethics who spend our career reading about, writing about, talking about informed consent. If you want to overcome someone's autonomy, what are the situations where that's possible, right? So there is, this is not something that's just ethical, though, right? This is legally mandated. And there are many processes in place across all of healthcare to ensure that people's autonomy is not violated. And so if you violate someone's autonomy and the accreditation folks come and see that there's consent forms that are dated and timed after I did the procedure, we get dinged. Our endoscopy suite gets dinged. And if you have too many of those that you don't correct, you can lose your privileges. And if it lands on one physician that they aren't getting, adequate informed consent, that could be a lawsuit, right? So these are things that are ethical principles that we talk about and we write about and we pontificate about, but they're also regulated in our laws, in our practices, at all layers of healthcare to make sure that they're respected. And I have to say, uh, you'll see where I'm going with this. Justice really not so much, right? Non-maleficences, do no harm. It is also a core ethical principle, right? A core principle in medicine that we learn about in medical school, that we should do no harm and we don't want to hurt patients. But it's not just something that we take in our oaths and that we talk about when we get, we walk across the stage to receive our kind of, cap and gown. There are many safety checks to make sure that we do no harm to patients, right? And so there's infection control protocols. If you're on inpatient service, everybody wants to make sure you have a gown. Did you walk out of the room without washing your hands? There are people who police to make sure that you are not going to pass C. diff from patient to patient to patient. This is something that is happening in every hospital across the country. There are medication safety systems so that we scan medicines and make sure that patients are getting the right doses at the right time. There's surgical checklists. There are timeouts. Before I can put an endoscopy scope into a patient, we have to do a timeout and confirm that this is the right patient getting the right procedure. And there are many people to make sure that I don't skip past that. And how many surgeons and proceduralists like me would skip past that if there weren't checks in place, right? It's like, I know this is the right patient, right? But it never happens. I have never scoped a patient without a timeout because there are processes in place to make sure that Dr. Nephew gets this done, okay? And so a failure to uphold these things, if you've got C. diff running rampant through your hospital, if you've got, infections, you will not be reimbursed. Your hospital just will not be reimbursed. And within transplant, similarly, um, the MEL score was a system. It's designed in some ways to minimize harm, right? The MEL score, for those of you who don't do transplant, is an allocation score. It's a score that tells us how sick the liver is. It helps us decide who moves to the top of a transplant list. And so allocation is designed to take the sickest people first. And it's upheld through laws and policies to make sure that we're abiding by the MEL score, and the MEL score is what we're using to allocate organs. And so all of these protocols that are in place, safety protocols around medicine, around transplant, around surgical protocols, are all put in place so that we don't harm patients. And it's not just left to, well, I hope that Dr. Nephew doesn't harm patients. um, this is, there's lots of systems to make sure that I don't do that. You also have an obligation to not just not harm patients, right? We have a obligation. People don't pay us for us just not to harm them. They want us to be a benefit to them, right? And so beneficence says that healthcare providers are supposed to benefit patients and really act in their best interest. And we take the Hippocratic Oath, and that's a really big part of why we do what we do. But again, it's not just an oath, okay? They are evidence-based protocols that guide everything we do. That guide how we treat cancer, how we treat infection, how we treat preeclampsia. And if it's discovered that you're not following evidence-based protocols, you can lose your license, right? Because not only are you not supposed to hurt people, you're supposed to be providing care that's in their best interest. You're supposed to be benefiting them, following practice guidelines of the current best data. And so we meet in groups to make sure that we all are following the same practices, that, everybody in our group is doing pretty much the same thing. And so these are important parts of benefiting patients. In transplant, we do the same thing. We have listing criteria um, that explicitly kind of help us to identify the patients we're going to benefit the most from transplant. So these are things, again, that are regulated, codified in medical care to ensure we do the right thing. What about justice? Well, I would say there's lawlessness, anarchy. It's all over the place, right? There's not a similar understanding or codification in medicine that this principle is anywhere near as important as autonomy, non-malfeasance, and beneficence. And so, what kind of structural implementation do we have of justice in U.S. healthcare and transplant system? There's been some oaths that talk about justice. Okay, so the Declaration of Geneva, the original one in 1948 and the revised one in 2017 is probably the closest kind of code in medicine that we has that really gets at justice. That it says, I will not permit considerations of age, disease, disability, creed, ethnic origin, gender, nationality, political affiliation, race, sex, or social standing, or any other factor to intervene between my duty and my patient. And so I think that's pretty explicit kind of a justice statement. The modern Hippocratic Oath that was updated in 1964 kind of gets at it. It says, I will remember that I remain a member of society with a special obligation to allow all my fellow human to all my fellow human beings, those of sound mind and body, as well as the infirm. Maybe that's a justice statement. It's not quite as clear as the Declaration of Geneva, but maybe that's a justice statement. But beyond that, unlike the other ethical principles, this is rather debated and not embedded. It's talked about, it's discussed, it's argued, it's executive ordered, but it is not embedded in our practice. And there are really no systemic safeguards to really ensure or guarantee that anybody gets equitable care or equitable access to transplantation. And so justice is this kind of idea, if you've ever seen this giving tree, right? That everybody has access to the same apples, everybody's got the same tools, and then there's this perfect system where everything is equal. But unfortunately, that's not the world we live in. We live in a world of inequality, where there's unequal access to opportunity, and some people have privilege and some people don't, and people don't have ladders, and everybody's trying to get to the same place. But there's really no safeguards to ensure that that can happen. And so I hope I've got you thinking, even if I haven't convinced you, that the ethical principles that we all study, they mean something in healthcare. They're codified. They are part of why we do what we do, and they are abided by. And IRBs and everybody make sure that we do a good job, but not so much with justice. And I think that that's unfortunate, and I think that's why we are where we are today. And so we're going to talk a little bit about where we are today with disparities in liver transplantation, because I think this is a result of the lack of focus, code requirements in this space. And so we're just kind of out here willy-nilly, and that really doesn't get us anywhere. So cirrhosis is a pretty prevalent condition. Um, it was 110.6 per 100,000 in the 90s. Now we're at 132.5 per 100,000 in 2017. And you can just see that this bar graph is steadily inching up. And so while cirrhosis may not be a problem that comes to your mind like heart disease or breast cancer, but it is on the rise in the setting of alcohol epidemic and obesity epidemic. We expect that mortality from cirrhosis will continue to rise over the next decade. And so this is becoming a real serious public health issue. It's always been a public health issue, but it's becoming more to the attention of folks who may have been focused on other comorbidities than before. This is a complicated figure if you're not a hepatologist, but there's really just one thing I want to point out. And that is that if you have decompensated liver disease with complications, your 5-year survival is 85%. Or your 5-year mortality, excuse me, is 85%. So this not only is a condition that is on the rise, it is a quite morbid condition. And unlike other chronic diseases like kidney transplant, where you can go on dialysis and live a fairly decent life, perhaps, or heart failure, where you may even be able to get an LVAD and that can help pump your heart for several years. In liver transplantation, there's really no other solution. You either get transplanted or you die. There's really no bridge or temporizing measure. And so I think when we think about equity in solid organ transplantation, in liver disease, it's particularly important because of that lack of bridging therapy. We're doing more liver transplants than we've ever done before. Here at IU, we did, I think, 212 or so liver transplants this year. When I started here 8 years ago, I think we were doing 120. So we are doing more and more liver transplants, not just at IU, but around the country because of some of the advances in technology. But as you can see in this figure, that despite the fact that we're doing more liver transplants, which is in the red, look how high the wait list is, right? So just all these people who are on the wait list who will not get transplanted. And this is just the people on the wait list, right? So we're not even talking about the people who never make it to the wait list because of barriers in access to care. So the burden of people who are dying without transplant is probably a lot higher than what this figure can display. Disparities in access to transplant happen not just at the waitlisting space. They happen along the whole care cascade. This is a figure that I like from NASM, the National Academy of Science, Engineering, and Medicine. This is a report they did on transplantation, and it just takes you through some of the steps that people don't think about as much when they think about solid organ transplantation, because a lot of the disparities start all the way at the diagnosis and disease management step. Some people might not have needed a transplant if their Hep C had been diagnosed, right? And treated, because we can cure Hep C now. So awareness and education and all the things that lead up to referral evaluation. And then waitlisting doesn't come till here. And so much of the focus around justice and equity in transplantation, if there has been any, has been at this step, right? But there are all of these steps that happen before. And as we think about preventative care in chronic disease and organ transplantation, there's so many things upstream that we could do, in my mind, to kind of help this process. I'm going to share with you a few disparities for some groups so that you can kind of get a context of or idea about where we are, starting off with women. And this figure just describes kind of the steps in the care cascade from pre-evaluation, evaluation, waitlisting, and a post-liver transplant outcomes. And you can see that that print came out a little smaller than I expected, but women are less likely to move from diagnosis to evaluation from liver transplant. A study at the University of Michigan showed that women were less likely to be listed even when they're in evaluation, often due to active substance use issues than men. At the waitlisting step, women have a 50 to 30% higher waitlisting mortality than men, and are 20 to 30% less likely to undergo liver transplantation. And then post-liver transplant, women have lower quality of life scores, difficulty with psychological adjustment, distress, personal function. And so there are disparities for women at every step in the care cascade that could be explored. When you think about how long we've known about disparities in liver disease, or gender disparities in liver disease, the sex disparity was first described by Cynthia Moylan at Duke in 2008. And if you were to take how long we've known about it before we did anything about it, I think it's been maybe a year since we made a modification to the MELD score to correct for to give women a little bit of an extra boost. Okay, that just happened, but we identified this disparity in 2008. Uh-oh. Uh-oh. Assuming that we had done something about this many years ago, 800 women probably would have still been alive. And so doing nothing about these disparities and kind of just sitting on them and hoping that they're going to get better on their own without changing MELD scores, without really changing policies, is really life-altering and deadly for the populations who are at a disadvantage. Beyond gender, I'll show you a little race and SES data right here from IU. We looked at over 3,500 patients who were referred to IU for liver transplantation evaluation between 2011 and 2018. You can see the demographics of the people who are referred. 41% Medicaid, 12.5% rural, 39% women. So our referral patient population in many ways does mirror the population of Indiana, except for by race. All right, so 12% of Hoosiers are Black, and only 6% of those who are referred were Black, and understanding that there's a higher burden of liver disease in many racial and ethnic minority groups, we probably would expect to see over 12%. Just like in Medicaid, 40% of Hoosiers don't have Medicaid. I think it's somewhere in the 20 to 30% range, but that population has more liver disease. So as expected, you see that they're overrepresented. And so you would expect to see that probably in rural and in Black patients. When we looked at who was dying during eval for transplantation, we didn't see race or gender differences, but we did see that coming from a neighborhood that experiences poverty made you 50% more likely to die during transplant evaluation. This was when controlling for race, gender, individual socioeconomic status, disease comorbidity, liver disease severity, and this still stood the test of a robust evaluation. And then on the wait list, we saw the waitlisting, the neighborhood poverty was also associated with waitlisting. And so when people thinking about what are the solutions, how do you fix some of these disparities that I'm talking about? One of the things that comes to their mind is national policies, Medicaid expansion. I think we have a tendency to really want to push the buck on justice to somebody else, okay? And so that's how I thought when I first started doing this work. I said, I want to look at and see, how did Medicaid expansion help these problems? Because that's the way to fix health disparities. And so what we found when we looked at the impact of Medicaid expansion on access to the wait list for transplantation, we can see that in the kind of grayish blue bars that there was some small increase in Hispanic patients listing, but there was not the similar increase in white or Black patients. And so while policy is important, it is necessary. National policies around insurance are not sufficient to deal with the justice issues that we have in transplantation. Some people would say, well, our healthcare system is just not as robust. Well, I can tell you they have the same problem in Canada. Okay. So this is Canadian data looking at area level income and its association with liver transplant access. This is a population-based cohort over a 20-year period of individuals from Ontario, Canada. And what they found was that living in a poor neighborhood, once again, was associated with 50% less likelihood almost of being transplanted. And this is in a place where they have universal health care. And so again, I'm not knocking universal health care. I don't want to, or Medicaid expansion. I think that these are very important programs and that they are necessary for us to do the additional work we need to do to codify justice, but they aren't sufficient. And so this idea that if they just do more in Washington, this problem would go away is likely not true. There's more that's going to have to be done than just giving people universal health care to deal with the inequities that we have here in transplant and in healthcare in general. So what does the public think about our justice problem? Maybe it's just me. right? Maybe I'm the only person who has a problem with justice. Maybe it's just me. The seed was planted as a medical student and nobody else is bothered by this. That's not true. Okay. So the public doesn't trust us either. Okay. So this is data from the 2019 National Survey of Organ Donation Attitudes and Practices. It's over 10,000 participants in this survey. They oversample to make sure that they've got demographic representation of Asian Americans, Native Americans, Black Americans. It's a very well done study. And so if you look at the number of folks who believe our donation system is fair, it's about 66%. Maybe we think that's a win. But if I don't know. That's like my son coming home and telling me I got a 66%. It's like 40% of people don't think our distribution, our donation system is fair. I would say we have some work to do there. Um, if you ask people, do you have an equal chance of getting an organ if you're rich or poor? About 52% of people believe that to be true. So 50% of people don't believe you have an equal chance of getting an organ if you're poor. Okay. And then more striking and maybe hard to read is that 48% of people now believe that minorities are less likely to receive an organ transplantation. And you can see the increase. They do this study every 5 years or so. So you can see that went from 29 to 30 to 48%. We aren't just asking minorities this question. They ask everybody this question. Everybody knows the system isn't right, right? So people recognize and perceive the injustice. We're not like hiding back here in healthcare. They recognize that the system isn't quite right. Why is trust important in organ allocation? This is Art Kaplan quote. I don't believe everything he says, but I think this is a good one. Um, the values of altruism and autonomy, the foundations of organ procurement rest on the presumption that organs which are given freely, voluntarily, and altruistically will be distributed in a fair and impartial manner to those in need. Any policies, practices, or activities that suggest otherwise imperil the entire enterprise of voluntary and altruistic organ donation. And when the public declines, trust declines, so does organ donation rates. And that's been shown in several studies. And so the public's perception around organ transplantation and their perception of inequity and a lack of fairness, it just keeps that organ donation number low. You see how many people are on the wait list, right? If we want people to really buy into the system, then we've got to get over people's perceived, I don't even want to call it perceived, their recognition of the injustices in the system. And so this is something that in my mind, I just describe as kind of a vicious cycle, this justice trust cycle, right? So when justice is embedded into policies and practices, it builds trust. People trust the system, they perceive it to be fair, they think transplant is equitable and all is well. So when justice strengthens trust, trust increases participation in organ donation, and then participation reinforces justice because if everybody's involved in the system, everybody's making recommendations about how to move things forward. You've got community engagement, and you just go around this nice, pretty kind of justice trust cycle if things are going right. But when things are not going right, the cycle gets broken, right? So breaking the cycle through unequitable policies and practices leads to distrust, disengagement. People aren't a part of the process. They don't want to donate. They aren't a part of making rules about the system because they don't feel like they're even considered. And then you get widening disparities. So I don't think we're in the left box, unfortunately, when it comes to transplant. I think that this cycle is becoming broken, and it's evidence as 49% of Americans recognizing that really there's some unfairness that's happening. We looked at this question of whether or not people's perceived inequality would affect their likelihood to be a living donor. And so we used some of this organ attitude data. And this is a multivariable analysis. And you can kind of see here that even when controlling for race, income, whether or not you worked, what region of the country you lived in, whether you were rural, how much knowledge you had about transplant, your religion. If you perceive the system to be unfair, you were less likely to donate. And so, these things have consequences for all of us. And so when people are less likely to donate, more people die. We aren't the only people that show this. This is medical distrust and its association with the intention to donate. This was a study that was done in all African Americans, 585 African American survey participants. And you can see that people's verbal intention to donate, that kind of first stage of change, even when controlling for other factors, was associated with medical distrust. And so, in a cohort of 10,000 kind of diverse subjects in our study, even looking particularly at minoritized groups, this idea of not trusting the system to be fair and just has consequences that I think really affect all of us. How am I doing on time? Um, all right. All right. Okay. So I have time to dream. So what if I was going to reimagine a just transplant system? Um, yes, yes. There are questions at the end, if you want to put them in the chat or just unmute yourself, that's fine too. So if I was going to reimagine a just transplant system, I'm not going to go way out there, okay, with things that I don't think are possible. So this is my pragmatic wish list, okay? Um, the first and most important thing in my mind is national transplant equity metrics. And I hope that the whole talk has prepared you for this bullet point and you believe that this is the way to go. I hope I've convinced you that when we codify um, principles, ethical principles, they become true. They become practice. They become adhered to. And I think that, like every other ethical principle, this is the way to go with justice and equity. I think that this will drive many other things, including some of the other things I think that we practically need to help people through the system. We need an acknowledgement of social needs and health literacy. We need better access to care pathways, but I don't think those things are just going to happen. I think that those things will happen if we make them happen. Nobody likes the word regulation. But I do believe that thoughtful regulation, as we've talked about with autonomy and beneficence, can foster accountability. Nurses to check with me to make sure I'm doing the right thing. Resource allocation. We've got whole quality committees to try to make sure we don't have too much C. diff, and data-driven approaches. Poorly designed regulation, though, can incentivize gaming the system, and can really harm centers that don't have the resources to do the things that are going to be needed to meet those equity metrics. And so it's really important that if we were to come up with national equity metrics, that people who do this for a living, who understand equity, who understand transplant, are in the room to consider these things, to come up with something that's going to be useful. There are many examples outside of the ones I've given for regulation driving innovation in medicine. And so, hospital readmission programs, meaningful use programs, quality metrics in dialysis centers. These are all kind of regulations that have driven change and improved outcomes, especially in dialysis for patients. And so there is a framework for us coming up with regulations and them driving innovation and accountability and improving the care of patients and their families. What would be an example? What does that look like? One example might be dealing with catchment area mismatch. What does that mean? Does the transplant center's wait list reflect the demographics of the population it serves in any way? In a little bit of way. You would think that would be something that we would look at, but it's not. We don't define service areas in any way. There's no standard needs assessment. If you work at a federally qualified health center, if you've ever worked at one, there's a requirement that you define your service area. that you do a need assessment every 3 to 5 years for what the needs are, and that you act on the needs in the community. It's reasonable. If they're going to give you money, it's not a reasonable, unreasonable ask. We don't do that in transplant, and I think that we should. And I think that we would not ask a lot, right? You do a needs assessment, you outline a 5-year plan, you don't close the gap altogether. Maybe you close it by 10%, and we incentivize it in some way. Transplant, we don't tend to incentivize, we tend to penalize. If you don't have 92% post-transplant outcomes or better, then you're no longer a Blue Clear Shield center of distinction and things like that. And so everybody's pushing for that good post-transplant outcome. And we design all these systems to make sure everybody does well in the first year. It's driven a lot of innovation. But it's a penalization system. I think we have to think of ways to kind of incentivize things and do some positive parenting. I think that the first bullet point was kind of a national metric. The second bullet point, we're kind of coming up with social needs screening systems and access to care systems. This is something that we're working on. Our pilot study is funded by the NIH-funded, it's the R21. But my thought is that why is this, like, why do I have to have a grant to do this? Like, why is this not just what we do? Right? So we spent time engaging with community gastroenterologists, talking to them about what they thought they needed to get people to our transplant center, designing a referral toolkit, and putting together a set of systems that would help providers, patients, and GI practices. And we're rolling it out at 8 practices across Indiana. But when the money's gone, it's gone. Right? So then I have to try to apply for another grant to do what seems like to me good care. I'm going to skip this and end on the African American Transplant Access Program at Northwestern. I think this is another example of a grassroots effort to improve access to transplant. They're constantly looking for funding. It's a program that deals with distrust, cultural competency, psychological support, and health literacy. It's run by Danae Simpson. She's a Black transplant surgeon at Northwestern. Since she started the program in 2019, they increased referrals, they increased evaluations, and they increased listing of Black patients in the Chicago area. And so that's not a long time to have an impact. And she's doing this with one nurse coordinator, like one social worker and herself. And so transplants make hospital systems a lot of money. And so if you can do 20 more transplants, she's probably paid for her program. But she's constantly looking for funding, right? So in conclusion, I'll leave you with these few points. That these are ethical principles are coded into practice in healthcare and transplant. Why not justice? Gender, race, and SES disparities are prevalent at every step in the care journey, and insurance is really necessary, but probably not sufficient to fix the problem. We're going to need more than that. Public perception is important. It drives a cycle of disengagement that impacts marginalized folks, but also majority folks. Okay, so this is a problem that hurts everyone. And I imagine a system with smart regulation that really would facilitate community engaged solutions. And so I hope that, one day I'll get somebody to buy into that and we all aren't looking for funding for programs that really should be codified into our routine transplant care. I'd like to thank all the funders and my research team, and I'll pause here for any questions.
You can take questions from here in the room, and then there should be Q&A questions coming to you. I can't access it myself. I'm sorry. Otherwise, I would read them to you. Maybe Nick will take over your computer and look at the Q&A online, and we can see if anybody here in the room has a question.
Yeah. So there's one question in the chat. let's see, in residency, we heard frequently that wealthy non-US citizens were able to sometimes game the organ system by paying out of pocket for an organ transplant and bypassing the usual organ transplant protocols. This is in contrast to hearing over and over again that undocumented non-US citizens are not eligible for transplant. Can you clarify if this is true or not, and comment on your thoughts regarding transplant tourism? Ooh, that's a whole talk. But there are a few things I can kind of clarify. Um, Transplant of non-US citizens is transplant center and state specific. There is no national policy on transplant of non-US citizens. Many centers do not do it because of the cost, because in many states, you cannot get Medicaid as a non-US citizen. And if you can't get Medicaid, then you can't pay for transplant, you can't get your post-transplant meds. That's been our party line here at IU, is that undocumented immigrants cannot get insurance and then therefore cannot pay for transplant. So we have not been a center who does that. But there are centers in New York and in California that have funds set aside to transplant undocumented immigrants in certain cases. How do they decide? It's often young moms who have acute liver failure of pregnancy and in cases that they can kind of get philanthropy to kind of help with that. But that's not something we've done at IU. So a state and transplant center specific, there's no national policy that says you can't do it. I actually have a student who's working on a survey to get transplant center attitudes around that because she's on the global health track and was really interested in that. So she's pulling together a survey. So stay tuned for what folks think about that. In terms of gaming the organ donation system, you can't game it per se, but you can list at multiple centers if you have money. And so you can go to multiple centers in different regions, which may have different wait times, and be on the list at multiple centers around the country. And some people can't afford to do that. And then centers have different wait times depending on where they are. There's been a lot of policy to try to even out wait times across the country that haven't quite been effective. So there still are sometimes places where people used to come to Indiana for that. Our wait times used to be short before some policy changes. Or wait, this would be a place you want to list, Indiana, Florida. Um, Not as much anymore, but if you do have money, you can list at multiple centers. Mhm.
Is this? Oh, it is working. Great. Yeah. Thanks, Dr. Nephew, for the talk. Extremely well organized, all like flowed very logically. Appreciate it. I agree with this observation that we've done a much better job with three of the four sort of bioethical principles. And part of my reflection on that is like, as clinicians, we think at an individual level, like the patient in front of us, or maybe the patient the next day, like much easier. And so those principles are sort of like in practice, you can sort of see them and understand them more. The justice one, I think, what I think is that it's harder, right, to sort of grasp as a clinician, and not saying that we shouldn't do it. I think I'm just trying to explain maybe why this is. And then I say that and think about your final proposal as well. And they seem to be like large policy levers, policy solutions that you're advocating for. And I wondered, like, to whom would that responsibility fall on, do you think? I mean, you're identifying the grassroots efforts, which are sort of great, but like they found a champion, right? Like someone to really do this.
Right.
Is it the transplant centers? Is it the larger sort of national, organ allocation bodies that sort of do this? Who does this?
I think it's the larger organ allocation bodies. So the United Network of Organ Sharing sets our metrics for post-transplant survival, for wait list outcomes. The metrics that we are judged on come from them. And if you don't do well, they will shut your transplant center down. If you have too many people who are dying after transplant, which means that your listing criteria are not right. And so I can think about programs that this has happened to. And so I think, well, just like they regulate our post-transplant outcomes and some of our other outcomes, they need to think about how to set some metrics for this. I think that if they set the metrics, transplant centers will figure it out.
Yeah.
I don't think that they should tell us how to fix the problem. I think that they should acknowledge there is a problem worth fixing for all of us, tell us, by what margin we need to fix it. And then every transplant center is going to have different needs. What they do in Chicago for Black patients because of the patient population they have there may not work in Houston. They're going to be, but you will figure it out. And if you go across the country, all of us have different ways of managing patients in that first year post-transplant. We all get to that 92% goal, but everybody's kind of got a different formula for getting there. There's some principles that we share, and then some things that are unique to us everybody being 3 hours away for us in Indiana because we're the only transplant center in the state that they don't have to deal with in New York or Boston, where there's so many transplant centers, right? So we have to think about our 1-year survival and our patient population a bit differently. So I do think innovation will happen at the transplant center level, but I don't think there's impetus to spend the money to do it and to innovate and think creatively without some regulation that comes down from our governing bodies.
Yeah.
There's one more, yep. In my work with transplant teams, I have noticed a unique dual obligation that many clinicians do not feel or feel much less strongly. They seem to feel that traditional obligation to acting in the best interest of patients, but also feel a strong obligation to acting as stewards of scarce resource. Can you speak about your experience with this tension? Yeah. So, we as transplant providers, we are dealing with a scarce resource, and you want to give a scarce resource to the people who you think are going to do best with it, survive the most with it. And that may not be someone who's got poor social support or who are struggling in some of these areas post-transplant in your mind. How I deal with it is I let the transplant team deal with that. When I'm talking about my individual patient, I am advocating for that patient within reason. Okay. Like I'm not saying that I'm like transplanting like just anybody, but within reason, my commitment as that patient's doctor is to that patient, not to the system. And everybody else is on the committee can think about the system. But when I'm presenting my patient to get a transplant. And so I try not to think about who's not getting a transplant because I feel like that's not my job for an individual patient. And then I let all my colleagues think about that.
We have time for one more question. We're a little bit over. Is there another one online?
No, I don't think so.
To our final question, or maybe we should wrap up because it's 1:03. Do you mind?
No, sure.
Okay, we'll go ahead and wrap up because we're past time. Thank
you so much.
And we'll let you ask your question individually after. Thank you so much, Dr. Nephew.